We're going to go ahead and get started. I wanted to welcome everyone to the webinar. For those of you who don't know me, my name is Dr. Lauren Levine. I host and moderate these webinars. As usual, we've got a great turnout. Close to 500 people are registered. Hope that everyone is staying safe and healthy out there, and obviously commend all of you for being here this evening and continuing your dental education. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Burton can speak for as long as he needs. For those of you who have been on the webinars in the past, you know the format. The speaker will typically speak for 45 minutes to an hour, give or take. We're going to have a couple of special offers at the end from our sponsor, and then we do a Q&A session. We can't do verbal questions, obviously. We've got 500 people on, but all of you on your screen should have a GoToWebinar control panel. You can type in your questions as you think about them. I never know how many questions we're going to get. Sometimes we get 3, sometimes we get 103. I'll do my best to get to all the questions. If we don't get to yours individually, don't worry, I'll forward those along to GoldenDent, our sponsor, and someone will follow up with you as well. In the next few days, look for a couple of things. First off, the webinar is recorded. There will be a recording of the webinar that is sent to you that typically takes a day or two. So if for some reason you can't make it to the end, you got things going on, don't worry about it. You will get a copy of the entire presentation. During the webinar, Matt's going to talk about some of the systems and products that he uses, some which are exclusive to GoldenDent. I've had the pleasure of working with GoldenDent for, I think, around 10 years now. They're the ones that are bringing in these amazing speakers and this great content that we're always talking about. They're also the ones that handle the continuing education forms. I get a ton of questions usually after the webinar about the CE. The basic rule of thumb is there's nothing you need to do. When the webinar is over, you're not going to have a quiz or a test or registration or anything like that. I send that report of when you logged on and when you logged off to GoldenDent. They go through that report as long as you were here for the bulk of the webinar. I think it's 40 minutes, 45, whatever it is. They will then send out a CE form. Because of the number of people that are on the webinar, that can take around a week or so. They oftentimes get them out in 3 or 4 days. But if you don't have it, say, by a week tomorrow, feel free to reach out to me. I'll follow up with them and forward along your request. So with that out of the way, we've had the pleasure of having Dr. Burton speak once before. He is a general practitioner in a southern suburb of Chicago, where he's practiced for the last 15 years. He is passionate about dental innovation. If you were on the previous webinar, then you got to see that. He enjoys inventing and testing and developing products designed to enhance direct composite restorations. He's recently engaged in a licensing agreement with Garrison Dental Solutions. He's working with their team to develop a revolutionary matrix system, which is set to come out sometime early this year, if it's not already out. Additionally, over the past few years, he's become focused on utilizing forward-thinking technologies and embracing these advancements as crucial to office efficiency and case outcome. He's come to realize the importance of digital scanning and how software integration platforms are key elements to utilizing the scan data. Furthermore, he envisions 3D printing, iOS, and digital smile software as the future for dentistry. He believes it's time for offices to begin understanding what this technology is, and more importantly, how it can be practically integrated and become extremely effective on a daily basis in any office. So Matt, we're thrilled to have you back and looking forward to the presentation this evening.
Thank you, Lauren, and thank you, GoldenDent, for hosting this and bringing it all together. And good evening to everyone who's joined us tonight on this lovely Tuesday. We are about to get pummeled with snow in the Chicagoland area tomorrow for the first time this year, so looking forward to that, or at least my children are. But we'll dive right into it. But thank you again, Lauren, for the lovely introduction, as always. And yeah, let's get into it. And if anyone has any questions, type them in the chat box and we'll try to get to many of those as we can at the end. So tonight's webinar is Perfecting Digital Wax and 3D Software with Guided Laser Gingivectomy and Other Procedures. And Jason and I were talking earlier, Jason Phillips from GoldenDent, and we were just talking earlier about, you know, how much things are changing and how how awesome it is in the dental field right now. And this area of digital wax, I would say, has had by far the biggest impact on what I do, how I'm able to do things, the procedures that I'm doing, and how I'm able to control and just really achieve amazing results in many different facets of my practice. And so it's an exciting one that we'll jump into, and it's a fun one for me to teach. And so, as Lauren was saying, I'm a general dentist near Chicago, and I've actually been practicing 17 years. I need to update that bio, Lauren. I counted this year. I'm like, oh my gosh, it's been 17 years. And in the past, my practice was largely a restorative focus. So I took over a practice that was about 60 years old when I jumped in there, and two great dentists ran it before me. Super conservative dentists, very filling oriented, and so there was a ton of amalgams, things like that I needed to repair, a lot of fractured teeth, things like that. So that was a lot of my focus at the beginning, was kind of catching that stuff up. And then I got introduced to digital scanning in 2020. Totally changed the game for me. And the reason that I did that in 2020 was I had one patient who wanted to do Invisalign, and she would not do an impression. So she talked me into having iTero come in and let me use their scanner as a trial. After that, I never looked back. It's a funny how things happen. And as Lauren also mentioned, engineering mindset. I enjoy inventing restorative matrix devices, product development, problem solving. And I did just launch, I have to plug, we did just launch a quad matrix system just recently, Lauren, that you were talking about. And so, but why we're here tonight is that I'm fascinated with digital tech and this evolution that it brings and that it's brought to me. And everything you're going to see here tonight is what I do every single day. Like, I just used a lot of this stuff today in my office, and it's really given me control of a lot of different things that I had trouble controlling before. So tonight we'll go through what is digital planning and kind of understand what a digital planning workflow is, identify technologies available that create these digital planning workflows, and then figure out how digital planning can be effective and integrated into different areas of everyday procedures, which is what I like to call comprehensive control. Clinical case studies for a gingivectomy, clinical case study for a guided implant, and ultimately leave with an appreciation for how effective and efficient digital planning is for a lot of different procedures. So what is digital planning? So for those of you who are doing this or not doing this, it's just a really effective method for dentists to kind of pre-plan, to get an idea of what we're going to do, why we're going to do it, and you're going to get a look at what's going to be done or what's proposed to be done before we do any work on the patient, which is really nice. And it allows the dentist and the lab to identify potential complications ahead of time, right? So if you're looking at something and you're thinking in your mind, like, I want to do 6 veneers, but you start to get these digital waxes back and you see that 8 and 9 are going to be totally different lengths, then maybe you need to do a bit of a gingivectomy. And then knowing this ahead of time is a huge advantage, right? So we can pinpoint these things. You're able to identify, potential changes in the treatment plan before you even touch the patient. And I found that when you walk into a room with a patient and you have a plan, and you even if you change it at the beginning and you talk through it, then it sounds more like it's planned, like it's intentional, versus later on when the two teeth are not the same size and we're trying to figure out how to make it that way or how to fix it, then it becomes frustrating and complicated. And so it really helped me kind of keep the arrow pointing straight and keep things moving in a forward direction. And so in the end, advantage is efficiency, predictability, and execution. So what is a digital planning workflow? Essentially, what you do is you take a digital scan and you send it to your lab for a design and a plan, and then the lab will give you a guide, which is the key change. And that's really been, and I'm going to talk more about this later, but those guides that they base off of the digital plan have been a massive game changer. And I'm going to show you how guides are effective in direct restorative, indirect restorative, laser gingivectomies, implant planning, and guides. It's incredible, and it allows you to produce results in basically a color by number situation. So you take your scan, you send it to the lab, they come up with a digital plan, and then they basically give you these guides that you can utilize in your office to replicate that digital plan directly in the patient's mouth. So the digital wax is the first part of the digital plan. And what this does is it gives you the ability to clearly see and control what is being changed, like I said, before the work is done. The great thing about digital wax is, traditionally, when I was doing wax ups with labs, which I rarely did, I mean, we did them in dental school all the time. We were required to, and it was painful. It takes time, and now we don't have time anymore as practitioners, right? So we outsource it, so it costs money, and a lot of labs, they charge a lot of money for manual labor. So if someone's actually manually waxing a lot of this stuff up, it's going to cost a lot of money, which deters us from doing it, because if we don't even know that the patient's going to 100% be committed to this, then doing like a full mouth wax up on this type of situation is difficult. With the digital world, it's much more cost effective. You can get these for $15 to $20 a tooth, and you can tell the patient, look, we're coming up with a plan. I'm going to send this to a digital wax lab, and I'm going to charge you a diagnostic fee so we can figure out what we have to do. Is that okay with you? And ultimately, if they say no, at that point, I'm like, well, then they're probably not really interested in the amount of cost that this whole treatment's going to take, right? So it's kind of a bit of a weed out scenario right there to see how serious they are. But it's also a really fast and effective way to get a lot of information quickly. So this digital wax, and I was actually working on this patient earlier today, this digital wax was done in 2.5 days total, and that was with 3 back and forths with me to have them redesign a few things. And so it's a really nice way to get information quickly, because we want to keep moving, patients want to get things done, and sometimes we're time is of the essence, which is always, but the digital wax is one of the key components, and that's used by the laboratories. But it's a quick way to get a lot of information, and like I said, pinpoint potential problems or important areas or things that you really need to pay attention to. So the digital planning kind of comes from the digital wax. And what the digital planning allows us to do is, what I found the biggest advantage is multi-phase planning and visualization ahead of time. So like I was saying earlier, when a patient walks in and they're mentioning that, I don't like how crooked my teeth are, and look, my gums are uneven, and this tooth's bigger than that tooth, they'll give you a laundry list of things, right? And so the great thing with the digital platform is that you can get a scan and you can send it to different places. So I'll send a scan to Invisalign and get a free ClinCheck and kind of see what's going to move, what's not, and what is Invisalign going to solve. And then from there, kind of communicate with the patient and say, okay, look, the Invisalign is going to solve your crowding problem, right? Or your crooked teeth problem that you mentioned, but we're still going to have short teeth in this area, and those are going to be uneven. And so we're going to need to do something else, such as a gingivectomy, to really tie this all together and solve all your problems. And when they know that from the front end, and when you know it from the front end, then it makes it a really nice experience for everyone, because you have a plan, the patient knows what that plan is, and they know that the end result is going to be what they want. And so it really helps you figure out what you need to do, and on the front end, without having to start making things work in the end. And ultimately, what it's led to my office is, like I mentioned before, old school traditional wax ups and all this stuff. It's tough, and multi-phase dentistry is difficult to really be effective and predictable and efficiently control. Some offices crush it, that a lot of them, they just do nonstop full arch cases, but that's not what I do. I'm kind of treating different things in different rooms. So each room I walk into, I'm doing something different. But at the same time, I want to give precision, accuracy, and I want to give these patients that need these comprehensive cases, I want to give them what they deserve in these types of situations. And it allows, all the players to be in the same room. So one of the great things with digital waxes and digital planning is that if you're using specialists, you can share this information, and you can even send them the guides to tell them exactly where you want to end. If you're not doing the laser gingivectomy in office, then send them a guide and say, follow this, and this is exactly where my veneers are going to end, or my direct composites are going to end. And it gets everyone to play, the same game. And then it creates a workflow to provide us with the guides, like I said, to accurately to recreate this digital plan. And what is comprehensive control? Now, this is something that I've always dreamed of, and I found it. And so I've always wanted to be able to properly quarterback the situation, which is that was the last line of the last slide, but it can be difficult to do. And, when I was younger and when my specialists were younger, we would spend a lot of time on the phone, but now everyone is older and has kids and has a lot of things going on, and it gets hard to get everyone in the same room. And what's become the center of the room for me is the digital wax. And what it ties together is, the orthodontist, oral surgery, perio tissue specialist, and me as the restorative dentist. And that was kind of my theory at the beginning. And then what I've learned is that it's actually helped me become more controlling in the orthodontic, perio tissue, and oral surgery category, and that these guides have really opened the door for me to give me some confidence in knowing that the pre-planning that's happening in all this, and identifying potential issues and being able to control those issues, has really allowed me to become all four of these bubbles around that digital wax. And so it's very, it's very comprehensive. So you can use it as the quarterback to guide all these other areas outside of your office if you outsource it, or it can help you become the person that does these procedures and really becomes the control of the entire situation and treatment plan. So the big difference maker of today is guides. So the digital planning versus what we used to do with, just traditional wax ups and things like that, is that we would have this beautiful wax up done on a stone model, and it would show up in my office, and it'd be like, no one touched that because it's gorgeous. No one drop that, please. But it didn't tell me a lot of information. Sure, I could take a silicone mold of that, or an impression, and use it for a temporary guide and all that jazz. But it didn't tell me a lot of things. It left out a lot of, critical information that I need as the doctor that's using it in the case at the procedure time. And so the really interesting thing about this whole digital platform world right now is the creation of these guides. And these guides are accurate. I started testing it in direct restorative because that was basically the simplest thing that I could do with it, right? You can't, even if it wasn't right, I could reshape the tooth or something. But it's turned me to gingivectomies and now implants. And it's really amazing that we can control everything through guides. And so whatever that digital plan comes up with, I can put that in the patient's mouth, and this thing tells me how to achieve that exact situation. So digital planning to guided procedures, workflow overview. So the first thing we do, grab our digital information, like I said, and then we send it to our lab, and the digital plan is created. Cost effective, time efficient. Step 2, information is transferred back to us via a guide. So based on that digital wax, a guide is fabricated. Now, these guides can be fabricated in different ways. If you have a 3D printer in your office, these online labs, and the lab that I use that you'll see through most of this for a lot of my online digital is Evident Dental Lab, EVIDENT, Evident Dental Lab. They're great. They're very, very communicative. They will get back to you, and you're dealing with a real person, and they will make the changes that you request. And they're very fast, and they do a really good job. And so for cases like this, I source to them, and I've had really good luck with them. And so if you have a 3D printer in your office, then they can just send you an STL file and you can print this in-house. If you don't have a 3D printer, don't worry, they'll ship you one. Then we take that guide that's created from the digital platform and we can put it directly into the patient's mouth, and then we just follow the lines and connect the dots. And it's pretty incredible what I've been able to achieve with this type of technology. So the next question that we all have is, okay, how can they be utilized in everyday workflows? When I started entering the digital world, my biggest qualm with a lot of the things that I was learning in the courses that I was attending was it was all based around full mouth rehabilitation. And I think that has a lot of different meanings. I think a lot of patients need a lot of things, but it doesn't have to be 28 crowns, and it doesn't have to be complicated. So I wanted to find a way to utilize this technology in as close to as many everyday procedures as I could, but utilize it in a way that was very effective, and it was producing results that in areas that I would not go into, or B, that were very difficult. For example, direct composite veneers. It's tough. I've taken plenty of hands-on courses on how to do this, and I tip my hat to those doctors that could sit there and shape these things, and see every critical angle and layer and do all these things, and it's incredible. It's amazing, but it wasn't for me. I was exhausted, and I felt like dying at the end of those appointments. And so finding ways that I could utilize this technology to gain me an advantage in those areas and to improve them, was really what I wanted. In turn, also jump into different areas that I always wanted to do, but I didn't really have the confidence to do them because I was unsure, right? I'm very sure about restorative dentistry, but there's some other things that I'm just not sure about. So finding ways to integrate the digital in my office in multiple facets so I could use it almost every single day, it was the goal. And that's what we're here to talk about tonight. The first thing we're going to do is go over the first case rather, is just kind of go over a quick overview of direct composite utilization with this. I'm not going to jump into this case deeply. I'm going to skim over the top of it. You may have questions. I'll be happy to answer them at the end, but we're going to spend a lot of time on the gingivectomy and implant course. But I did want to mention this because I do think it matters. So guided direct restorative is what I call it, right? So we're doing direct restorative restorations. We're using a guide to produce them. And it's a great way to do conservative dentistry. Composite it's kind of back. I don't think it ever went anywhere, but it's a great material to restore cases for aesthetics, and it's super conservative. It's cost effective. Let me rephrase that. It's cost effective as long as it doesn't take a ton of time for the doctor, right? And so if it can be streamlined and be efficient and not be completely exhausting, then it's cost effective for everyone, and not just the patient. But the reality is the materials today that we have are just fabulous, right? I mean, composite resin's really never been better since I got out of dental school. But the biggest hang up for me was that the things were just a pain in the butt to do, and I felt defeated, and I felt like it wasn't worth my time. But I knew that it was a great material and it was a great way to solve problems. So that's where digital and these guided restorative procedures and methods have really changed it. So we scan the patient and we send it in. And in this case, I just did four digital waxes here for the two laterals and the two centrals. And you can see she had a diastema here, and she's been dealing with this for forever. And then she finally got to the point, she's like, I want to change how I look. And she's a real estate agent, and she was just like, you know what, I'm not happy with how they look. I'm not totally in love with the color, but the shape and around the gum line and all of this stuff. But overall, her teeth structure wise were in great shape, like no restorations on there at all, no caries, just some abfraction up in these areas here. And so the method that I chose to do this was direct composite. So I had my lab wax up the four teeth in the front, and I left the canines because I was just going to hand sculpt those abfraction areas and kind of blend the color. And so digital design comes back, and I'm able to see all of these things. And the reason I showed this view in the bottom left corner is that one really important item that's taken into account during digital waxing is occlusion. And when we're doing direct composite veneers in the anterior, if you're going to put that composite past an incisal edge or even on the lingual wall, that composite needs to be moving at the right angle. It can't have any shear edges, no interferences, because as soon as they catch that, they're going to bust it. And so this technology allows us to take occlusion into account and really ensure that we're putting this composite at the right incisal angle, and we're not going to have chipping and busting issues when it's all done. It's a great way to have a ton of control. So when we approve our digital model, one of the key components here is called the every other wax. Here. So I approve this, and my laboratory will strip away the two of the teeth that were waxed up. And what that does is it creates two models for me, one with only two of the restorations and then one with all of them. And the first model here is model number 1. That goes in the mouth, and I inject these two teeth, number 7 and number 9. And then I put the second mold in, and I inject 8 and I inject 10. And the reason for this is so they don't bond together. So when I restore these, I will put Teflon tape around the restored teeth before I put mold number 2 in, and the Teflon tape will fit. It's thin enough, it fits right under these silicone molds, and it just gives you incredible precision. And you get results like this in a very little time. You know, this appointment was a couple of hours, and it was a complete game changer for that patient. I did not remove any tooth on this. I scuffed the abfractions, packed cord, placed them, etched, bonded, injection mold, finished and polished, and that's what we have. And so the technology is incredible, and that's what created this. It allowed me to do it in a very efficient manner. Patient was thrilled. And actually, she was just in for it was 2 years after we had done this, and she was just in for a hygiene check a few days ago, and they looked just like they did. And there's a lot of advantages to doing the injection molding. And like I said, you can control the occlusion, and you limit your risk of incisal edge fracture. You can control all these contours that are really hard to control otherwise when you're sculpting by hand. And one of the really cool things is that the oxygen inhibition layer is kind of included with the silicone injection mold, because the composite is choked off from oxygen while you're curing it. And so you get a really nice, hard, fine polish at the end. And so it's a really, really great way to make this a cost-effective thing for doctors and for patients. And you can get really great results like this in a very short amount of time. And it keeps you profitable, and it keeps your patients happy. And believe me, they're going to tell their friends about it, that they walked in and then 2 hours later they walked out, looking like that. A little numb, but quite a transformation. Okay, now we're going to jump into more surgical area of these digital guides. And the first thing we're going to go through is the gingivectomy, which was on the title tonight. So diving right into the case. And this case was relatively recent. I started working on this patient last year, and 38-year-old female. I really want to improve my smile. My teeth are so crooked. I'm kind of taking words from before, right? My bite is weird, and I don't like how short my teeth look. And so scanned the patient, and this was in a hygiene check. And I had been seeing her for a few years and kind of buttoning up some posterior fillings and things like that. But she came in one day. I was like, I want to change this. I want to fix it. Can you fix it, and how do we do it? And I think it's important that, when you're listening to the patient's list of concerns, that we understand what those concerns are. And not all those concerns are going to be solved by one thing. And I've done it where, when I first got into Invisalign, I would just be like, oh, Invisalign's going to fix Invisalign's going to fix everything. And then you get done, and then, the laterals were gingival architecture was off and all those things. And so it kind of trained me to start to realize, okay, utilizing this digital software, if I pay attention to what it's showing me, then it's going to kind of guide the way and show me exactly what we need to do. And ultimately, she has two major concerns, and they're not achievable with a single tool. Back to this, right? We have the orthodontist, perio tissue involved in this. Digital wax is at the center, helping me figure it out. So after that planning, and I had kind of gone over this before briefly, but we determined 6 months of Invisalign to correct the bite and all that jazz, and then followed by a guided laser gingivectomy tissue recontouring on 5 to 12. And Invisalign is going to do a few things for us. It's going to intrude the maxillary and the mandibular incisors and get rid of her deep bite down there, which is causing some issues. And she was having some early TMD pain as well, and that can cause that deep bites common with that. Like I said, orthodontic movement though, it's not going to solve the clinical crown height issue for her. And so the digital planning and visualization really helped me, see this and understand it ahead of time. So when she came back a couple weeks later to kind of chit chat on everything, then I said, here's what we need to do and here's how we're going to do it. And she said, okay. So we put her in Invisalign for about 6 months, and you'll see that I say following near completion. And so whenever I'm doing cases like this, where I'm doing a combination of Invisalign and gingivectomy or Invisalign and injection mold direct composites, I'll get the patient to a point where the bite is stabilized enough, or I've created enough space or got the teeth in a close enough position to do the next step, whether it be a gingivectomy or an injection mold. And then I'll finish them up or polish them off with a couple more trays of Invisalign just to tie it all together. And so I'll get them to this point, and then say, okay, we're going to do the next step now, and then we're going to throw you in a couple more trays and finish it off. And I found that to be very effective in just not putting all the pressure on one procedure, right? So in other words, like the gingivectomy, if things heal a little bit differently, then you can control some of the tissue heights and things like that with further Invisalign. And so at this point, we take probing depths to make sure that we have enough room to have biological width when we're done, and then relay the information to my digital lab with a new scan. So this is the scan on that day, photographs, and instructions to remove approximately 3 millimeters of tissue. So the important thing on the last slide that I talked about was photographs. Send photographs to your lab. I have a simple iPad in my office, and we take pictures all of the time, and photographs are so helpful to the laboratories when they're trying to figure out patient smile lines, lip lines, things like that. Like, they can't guess that stuff off of digital scans. So photographs have almost as much value as the digital scan when you're trying to plan things like this. And the more information that you provide your laboratory, the better result that you're going to get, right? Because you can communicate with them, and sometimes they'll call me and say, hey doc, I saw in the photograph that such and such tooth or whatever, and it's like, do you want to address that now? And it's like, yeah, sure, let's do it. And so photographs are just as valuable as the digital scan. And so I send them the instructions, and they send me back like a sketched out version of the tissue that would be removed. And at this point, if you want to change something, you can change it. You can say, no, actually, I want a little more tissue off of that, or whatever, and you can have them modify it. And like I said, photographs are important. The lab takes a smile into account, send the photos. And if you look at this patient here in this photograph versus the scan, you would never guess that her lip line, she smiles higher on her left side. And so are we going to set the gingival edges based on what the digital scan or her lip, right? And so a lot of the tissue, extra tissue, was removed on the patient's left side to help create a balanced look, even though it's not technically balanced. But when the patient smiles, we can't tell them that they smile crooked and that's what's wrong. It's just how they smile. And so finding out these things and how to address them early and how to make the patient happy and get what they want is critical. And that's why photos are super important. So I approved it. Lab went to the fabrication and sent us the STL file. And like I said, the digital guide, this is the thing. This thing is built to transfer exactly the information that we had here right into the patient's mouth. And then it becomes a color by number. And also keep in mind, this is a template, but it's a really good one. And if you want to make changes on the run when you're in the mouth, then you can do it. But at least you're not having to sit there and figure out what's level, what's not. You know, am I high enough? Do I need to go lower here? Especially in a numb patient, because it can become very difficult. So prior to anesthesia, I always verify fit of the guide. These guides fit like accurately, but they're relatively passive over the tissues. And so you're not going to hurt them, but I always make sure everything fits just right before I numb the entire patient's face. And I use, for gingivectomies, I use carbocaine, and this stuff is really great. It's fast acting, it doesn't last forever, and it's relatively gentle when you're placing it too. Like patients don't flinch, they don't feel that burn as much, and so this stuff is really great. It's just a fun fact. And a quick tip to always protect myself in these situations, I pack 00 gingival retraction cord blue before I do any of these gingivectomies. And the reason I do that is because if I see cord while I'm lasering, then I know that I'm close to biologic width. And so it's a great little way to always have like a bit of a parachute in these situations where you don't have to worry about invading that space. So just packing that cord, taking a couple minutes to do that, and leaving it a certain color. You know, don't pack it white because it's kind of hard to see, especially when the laser's cauterizing the tissue. So I pack blue so it's dark, so I'll see it when I'm running through there. But it's a great little way to know that, security blanket, I guess. You just know where you're at. So here we have the guide in the mouth, fit confirmed, and I like to make mine. They have a few different materials you can make these guides out of, but I love transparent. I love clear, and I use that for my implant guides as well. And it's just a really great way to be able to see everything. So when I seat this in there, I can see the incisal edges of all my teeth are lined up and they're in the chute, right? So I know that my guide is seated. I don't have to worry about anything being off balance or unlevel. It's there. So the transparency of this material makes it very, very easy to see everything. And so now we have our guide in, patient's numb, cords packed. Now we bust out our LX16 laser, this thing is awesome. I've used lasers, one other laser before, and I just had a real simple diode laser, the Pioneer diode laser, which is a great little nugget. This thing is incredible. It does the job. I was very impressed with the cutting capabilities and just the smoothness of the cut of this laser. And I just take that filament that's right here, and you can just run it right along the guide window, okay? And that's going to tell you exactly what tissue to remove. And so it's a really, really smooth laser, and I was very impressed. I know Jason, the first time I used it, I called him right away, and I was like, that thing is awesome. So guide popped out, and then I touch up after the guide's out. And so I touch up the areas right in here, interproximally, just make sure, because sometimes these guides will leave a little extra tissue down there. So I'll just pinch that off with the laser. But also, if you're removing 3 millimeters of tissue, by the time you get up here, that tissue is going to be quite thick compared to what it was, all the way down here. And so I'll just take my laser and run it on a slightly lower power and just kind of bevel the facial aspect of that tissue. And it just takes a couple seconds to do that per tooth, and just to make sure that you have a nice, thinning of the tissue there in that area to help promote healing and get it to structure the way you want it to. Post-op instructions are key for these types of things, and I've learned that. I used to tell patients after I did something, and the reason I bring this up is from what I've learned. I used to tell patients when I would do something, yeah, just leave the area alone for a few days. And I saw that they would come back and everything would still be like puffy and inflamed and kind of, yeah, you know, and so if you tell people to be careful with something, some of them won't touch it until you see them again. So what I've discovered is that I actually tell them to do the opposite. I say light brushing first night, just, you know, just take it easy on it tonight. Tomorrow, I want you to hit it hard, just like everything else. And in a couple days, I want you to hit it even harder. You may notice bleeding. It may be tender. You may not love it. You can curse at me under your breath while you're doing it. That's fine, but it's going to help your tissue stimulate, and it's going to help promote healing in a much faster manner and keep all that stuff away. And I found that with everything from like crown preps, when I temporize them and things like that. If I had to go subgingival, I used to tell them to kind of like steer away from it. It might be a little tender. Now I'm like, hit it. Even if it hurts, hit it. And tissue really responds well to that. So just kind of having that communication with them up front, telling them what to expect. You know, they're not going to be worried if it hurts and it bleeds, if you told them that it was going to hurt and it was going to bleed. And the results with that really turn around much faster, I found in my practice. So this was seen at 2 weeks. I'm not sure why this is so blurry, but she's healing well. Just some little red lines around these areas, which is expected at this point. And like I said, I like to leave some Invisalign for after, and so we'll scan her that day. And this kind of gives you a better appreciation for how much tooth we exposed, right? How much clinical crown we were able to create with simply a laser gingivectomy. And you can see here, sorry, that photo was blurry, but you can just see like the little, we still have just some inflammation minor right along those gum line of those teeth, but we still have stippling in a lot of areas. And we send that off to Invisalign for further treatment. And then this was 4-week follow-up at her Invisalign progress scan Invisalign progress delivery. And so looks pretty good. She's very happy. You know, there's no more nothing, you know, I mean, there was really never any tenderness. You'll notice that with lasers is that they're really amazing at doing this, and they don't cause the patient a lot of discomfort. Just have them hit it with a toothbrush and it's great, stimulate everything. But she's now finishing up her Invisalign. So this is, like I said, this is a live active case, and she was just in maybe like a week or two ago when I snapped this photo, and she's already thrilled. She's not sure why we're still doing the Invisalign for a couple more trays, but I just wanted to button up a few things. But we were able to solve everything that she wanted to solve. And the best part about cases like this is that my footprint in this mouth is 0, right? Like I don't have any restorative material in there at all. This is the patient's. When they leave, they're good. You know, I don't have to worry about my fillings busting. I don't have to worry about veneers popping off. The patient got everything she wanted, and there's like no maintenance. So it's a great way to treat. And it makes me feel good when I complete cases like this, and knowing that I really don't have to worry about anything in there, and that she's, you know, that she's well off. All right, and a note. So these guides can actually be used for hard and soft tissue. I had this question on a prior course. So they can be used for crown lengthening, hard tissue crown lengthening, and they can give you 2 different guides. They can give you one for the hard tissue, and then give you one for the soft tissue later. So if you really wanted to pinpoint control of a lot of things for, you know, aesthetic crown lengthening and veneer cases and things like that, you can control all of those things with this type of scenario. And if you're not doing the clinical hard tissue crown lengthening in your office, then you can provide your specialists with these guides that can communicate with them exactly where you want these things based off the plan that you have. And so when you get the patient back, you're not having to worry about, well, I hope they did, you know, I hope they did a good job. I hope they did what I wanted, or I hope they had the same vision as me. And so you can communicate this with those doctors as well. All right, and finally, to tie it all together, we're going to go over a digitally guided implant. So this has been my latest adventure. And so about 7 years ago, I thought, man, I'd love to place implants, but I really don't have time to practice and get good at it. I'm a perfectionist. I need to know that what I'm doing is proper, is working. And we all know how we learn that is through experience, right? And experience brings successes and failures. And, you know, with restorative dentistry, I've had enough failures to understand how to keep myself out of trouble. But with things like this, it was kind of a new category. But with the digital planning models and things like that, it kind of gives you a little boost of confidence because you have a plan, and that plan's not guesswork. You can actually see every component of the situation ahead of time, and you're involving your restorative lab before the patient's touched to plan the crown and figure out what you need to do and where that implant needs to go. And it's pretty powerful. The great thing about this, the digital planning, if anything, even if you're not going to do implants in your office, is that it allows you to consider both the final restoration and the implant placement at the same time. How many of us have been in the situation where we get it back from our specialist and that implant's on an unforgivable angle in the anterior, and we're trying to figure out what to do, and we're taking the scan or taking the fixture level impression, and we're just, the patient's like, how's it look, doc? Yeah, it looks fine, it integrated. And boy, and you're thinking in the back of your head, I hope my lab tech can pull off a miracle, right? And you get into those situations where it's like, and it's tough, and sometimes it works and sometimes it doesn't. It can be very frustrating for the dentist. It can be very frustrating for the patient, and they don't understand why. I spent all this money and I went through all this, and now it gets a bunch of food stuck under it, or it doesn't look good. And so having a plan from the beginning that really anticipates both things, the restoration and the implant, is super important. And when you think about it, it makes total sense, but we've kind of done it backwards for so long. And so the biggest thing with implants is, there's two parts of the implant really, right? Or two critical areas. And one of them's bone. Bone is everything that any specialist will talk about. Bone, 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 bone. And bone is very important, but it's important in the initial integration of the implant, right? So like stage 1 of the implant, and it is important, and it varies, right? The height of it, the shape of it, the health of it, the type of it. Do we have enough where we need it? And it's hard to see the true architecture of that. And traditionally, our vision was gained through big flaps, and that affects the tissue. But now we can know the exact architecture of the bone. And what you're seeing, these images here are CBCTs. So I don't have one in my office, not yet anyway, but one of my buddies does down the street, and I struck a deal with him to be able to send patients down to him to get these, and he just sends me invoices, and I pay him for each one, and then I transfer that cost. But it's the ability to see the exact bone architecture of where we're going to be placing that implant with incredible precision, right? We can see where our cortical bone is. We can see where the IAN is. We can see if there's any defects that are in the cortical plate or surrounding structures, or any potential issues. And this is when you can start to see this stuff from the beginning, and you can know exactly how far you are from the cortical plate or the lingual plate on both sides before you even touch anything. Then it's a great little boost of confidence, and you know that what you're doing is going to have a larger chance of success. It doesn't work every time, but this is giving you the best opportunity to do so. And so, like I was kind of hinting towards earlier, two things with implants. Bone, we've already kind of talked about, largely the focus with the initial stabilization, right? So it's the most important thing when we're placing the implant in. Go where the bone is. But ultimately, what I've really discovered is, after 17 years of restoring these, is that the tissue has a huge play in this. It has a huge role, and it's the long play of it. The tissue health around the implant really determines how well an implant functions for the patient, how little they notice it, and ultimately how long it stays in there. And so both things need to be considered, right? We need to consider the tissue and the bone on the day one, and that's going to give us the best case scenario for patient success. So with these guided implants, one of the things that I noticed right away is that I have better success at managing tissue. So if you have to flap, flap. This is not like an anti-flap lecture at all. Sometimes you're gonna have to flap because you need to do, auxiliary grafting and all that jazz. Like you have to. But in cases where we don't have to, and we know we don't have to because the CT scan showed us that we didn't have to, and we knew exactly where that implant was gonna go, then all of a sudden we can be more conservative with our tissue and more friendly with it. And on surgery days, when we're more friendly with it, we can start to kind of tell it what to do, right? We can contour it with a proper size healing cap. And now we have 3D printed tissue healing caps, like custom, that if you want to do that, you can have those made based off the bottom emergence of the crown that's going to be on the final implant. You could screw that down on the tissue on the surgery day, so we can control the tissue on that particular date and really drive everything toward, the final result and with amazing success. And like I said, the functionality and aesthetics, tissue management matters, and that's one thing I've really learned is that, the tissue, it's a big deal, especially with implants. We tend to center everything around bone, but tissue matters, and the functionality and the aesthetics of implant crowns. When you see these docs on Instagram or, some of these really cool cases that come through, they did a great job of tissue management. And that's really an important thing. But in the past, it was kind of difficult to manage. And the digital world now gives us an opportunity to be better at that on the front end, or to be conscious of it and at least consider it before we start doing surgeries. So into the clinical case. This patient walked into my office. My tooth is wiggly and it hurts to bite down. Not hurts. I'll have to fix that typo. Then on number 4, I see a mobile cusp and it's tender to pressure and lateral touch. So I send her down the street because my x-ray doesn't show me anything. I send her down the street to my buddy's office, and pretty cool CBCT image. You can see there's a horizontal vertical fracture right down the middle of this tooth. And if you look back at this tooth didn't even have a filling on it, no restoration at all. And so she vertically fractured it. She was chewing, what was it? I think it was granola, and she hit there was literally a rock in the granola, and she bit down on it and just split that tooth right in half. And so the great thing about this technology is that if you're in doubt on anything, you can see everything on these in 3 dimensions, and it's really incredible. And so we inspected everything on this CBCT, found the fracture obviously, but then I can zoom through it and inspect for like any cortical plate defects or anything that could be in my way. So this is the situation, vertical fracture. So I gave her 3 options: 3-unit, nothing, or implant. She opted for implant, and I numbed her on that day, and I reduced the occlusion on this just to get her out of bite on this, and then limped her along and said, I'm going to take the scan that I just took, and I'm going to take the CT scan, I'm going to send it to my lab, and I'm going to have a guide made, and we're going to be able to drop this thing in on the same day. So she was willing to do that. Gave her some ibuprofen, amoxicillin. Obviously, if things turned or the tissue wasn't having it, we would have to change plans. But the plan was, in 10 days, extract this and immediate implant placement. So in the meantime, we build our guide. And so this is another cross-sectional shot here of the CBCT. And so you can see around number 4, we have good bone around the whole root, and we're inspecting for anything that could cause problems. And so my restorative lab and my surgical lab techs jump in and they start fabricating my guide. So in about 2 days, I'm sent this, which is a planned 4mm implant. And I use Neodent in my office. And so this is for the Neodent Easy Guide. And so they'll show me all these different angles and give me strike measurements of cortical plate to the apex of the implant, in the thinnest areas all the way to the collar of the implant, and make sure it's dropped at least 2 millimeters below the lowest crestal bone at the day of surgery, so we have a little room for some bone resorption after surgery. And they're also factoring in the final restoration, which in this case was kind of cool because they just used the patient's current tooth as the factor in that. but it allows us to know that we're avoiding sinuses, that we're dropping that implant right in the heart of the bone. And a few days later, I've approved it, plan approved, surgical guides fabricated, they ship it to me. And if anyone's not familiar with the surgical guides, I know GoldenDent carries one as well. It's our surgical guide osteotomy drills. They're fabulous. They fit the sleeve of this guide, and they just show you where to go. So this is just neodents here, but there's literally like a sleeve on the drills that falls that goes right into the sleeve in the guide, and it controls the angle, the pitch, the depth, everything. It's within incredible precision. It's really amazing. So it's another color by number thing. So we have our surgical guide, and again, clear acrylic, right? So I can see through it, but also we have cutouts of the teeth in certain areas. And the reason is that I'm able to see and know that that guide 100% is seated all the way. And so that's a really important feature to have in these. So time to get to work, patient anesthetized, few seconds later, this thing's removed, and there's an amazing instrument, and I'm going to talk about it next, is the wedge elevator. I took a course from Art Navarian, and if you guys haven't taken it, and I'll talk about this in a little bit, he is absolutely incredible. He has the best course on atraumatic extractions, and he has a few little instruments that I've been trying to atraumatically extract in my office for 15 years. And after I took that course, all of a sudden I was atraumatically extracting. And really, really awesome tools. And tools are important, but that course and this tool made a major impact on me to be able to do that. So as you can see here, no flap reflected. And the big thing when you're doing immediates, and I'm punching through a lot of virgin bone on this implant. I don't know if you saw that on the guide or the guide plan before, but the great thing about the guide is that it's not going to allow my osteotomy drill to slide buckle, right? Because it's going to want to follow the extraction site. So this guide's going to really make sure that my drill is going in the proper plane and creating the path towards the lingual side without slipping. A couple minutes later, it was literally two or three drill sequences, in, out, and 5mm healing cap. I had a little, just kind of an irregular area of tissue over here, or, I kind of dented the tissue a little bit. So I just placed the suture right there to make sure that it pulled taut and that it didn't do anything funny there. But literally, this is immediately after that was done. And this whole procedure was done in less than an hour. An immediate post-op. So the 4-month follow-up and all that, TBD, but the healing and things like this, it's not every case that you can do this for, but in certain cases where you can control the narrative and you have a way to predictably place these implants and know that this guide's going to really drive the whole thing, and you're considering all the potential issues ahead of time, then it's a really nice way to do these things and confidently achieve, what you want to achieve. And another little trick that I've learned is that when I scan patients, if it's not for like an immediate, if you see these marks here, I have a whole box of washable markers. They're black and they just wipe off the patient's gums, but I'll mark the attached keratinized tissue line on the scans. So that way my lab technician knows exactly roughly where to put the implant in the middle, so I have adequate attached gingiva on both sides, because sometimes it'll swoop in on the buckle or do weird things. And so it's not easy to always tell where that's at, even on a digital scan, they can't see that line. And so I'll mark it on a marker and transfer that data to my laboratory. And one lesson I've learned quickly is communicate with your lab. When you're jumping into this stuff, if you're going to jump into it, or even if you're referring this stuff out to your specialist, ask questions, right? And say strike measurements in these areas. These are critical areas. I want to make sure I'm where I need to be. And they will give you real-time data and tell you exactly where that implant's going. So don't ever assume. I always say, it's just don't ever assume that everyone's on the same page. Just communicate, make sure that everyone's on the same page, and then proof is in the pudding like this. All right. Having the right stuff is important. And as I mentioned before, the wedge elevator is awesome. Now, grafting material, I didn't use any on this case, but if I do, I use the Goldos particulate. This stuff is great. I've used others, and the really nice thing about this material, and I use this stuff all the time, is its handleability. And so when it mixes, it becomes like a, I don't know, it's like a paste, but not. It's not sticky or anything, but you're able to really like pack it into extraction sites. Some of the materials that I've used from others it's a bit gravelly, and so this stuff is great, and it's really easy to pack, and it heals great. And then I'll top those off with osteogen plugs, and these things are super easy. It's also a bone graft material, and I'll put my particulate in the base, and then I'll take one of these plugs and just cut the top off of it and just put that over the top and suture. It's really a great way to know that your graft material, if you don't need a membrane, it kind of acts as a membrane, and it really helps promote the tissue healing and the bone healing all the way up to the crest. So these things really simplify it too. And like I said, the course to consider, Dr. Nazarian's course is incredible. I took it last fall, and it was really one of the coolest courses I've ever been to. Two of the coolest days of my dental career of 17 years was spent with Dr. R. I mean, he's great. He's super practical. He's an everyday doc. You know, he's out there doing the same thing that we're doing every day, and so it's a really cool thing when your instructors are kind of on the same wavelength and have the same challenges as you do on a daily basis. It really leads to a special course. But this one, if anyone's thinking about getting into, you know, guided surgeries or atraumatic extractions and bone grafting and all that, and you can learn so much in these courses in so little time. It's really awesome. And that is all I have. So I'll hand it over to, I believe, Kurt for the rest.
Well, it's me for a second, it's Lauren, but I will hand it over to Kurt. So thank you, Matt. We do have some questions, but we're going to get to those afterwards. As I had mentioned at the beginning, these webinars don't happen unless we have excellent companies to work with. And Golden Dental Solutions, I've worked with them for over 10 years. They're the ones that bring in the speakers. And I had mentioned earlier that some of the things that Matt was showing are exclusive to GoldenDent. Kurt's going to come on, Kurt Lawler from GoldenDent. He will make a few special offers, and then we'll get to the Q&A session. So Kurt, take it away.
Thanks, Lauren. I appreciate it. This is Kurt Lawler with GoldenDent. We're, if you're not familiar with GoldenDent, we're based here in Detroit, Michigan. We're a third generational dental family. The first two generations were actual dentists and doing dentistry, and then now third generation here, we're in the product and educational aspect of dentistry. So we, like I said, are a Detroit-based company, and we've always operated under the principles of providing simple, predictable, and unconventional solutions. So we're always looking for really unique products, but that deliver clinically. And so I'm going to mention this first before I cover a couple slides. If you've joined our webinars in the past, you know we usually do give a promotional offer if there was anything that was mentioned on the webinar this evening, or if you're a regular customer and want to stock up on some products you're already using. Tonight's code is GOLD15, and that will save you 15% on anything on our website this evening, with exclusion of it doesn't work if there's like a 5+1 deal and some very limited things, but for the most part, it's everything on the site. We do these deals quickly. If you join our webinars in the past, you know we do them for 24 hours, so it expires tomorrow, February 12th. This is one of the products that was showed this evening, and it's actually the LX16 Plus. And so the difference is it's going to have the blue and the red laser ability. So the LX16 was just the red laser, and so the 16 Plus has both. So you're going to get your 450 blue and then your 976, which is your more traditional red laser wavelengths. With the webinar discount, it looks like it makes it around $4,200, which is pretty affordable for a diode laser. One of the things I really like about it is it has a really nice touch screen, so you can really find the procedure that you need to do, and it's really intuitive. You literally are just clicking buttons, you find the procedure you want to do, and then it'll tell you the tip to use and sets all the settings for you in sort of a preset manner. So if you have any questions about that, we have lots of videos on our website, and obviously you can give us a call. We'd be more than happy to explain further how this works. I don't have a ton of time to get into this, but it's been a popular product for us here at GoldenDent.
It's a smooth cutter.
Yeah, smooth cutter. So this is the class that was mentioned. So we've been doing these for a long time. So it's a live patient program, and what's really nice about the educational courses, it's not that you have to fly out of the country or have a special license or anything like that. Since we do it at a teaching facility, all the dentists that come are usually from out of the state of Michigan, so that's not an issue. We have like a blanket insurance policy and all that covered. We just get some documentation from you, like your dental license and a few things just to verify. Obviously, you're a licensed dentist to attend our class, and it is live patient, so you do all your own surgery. So we focus on extractions and grafting, but there's a lot of other components that are covered, obviously, whether it's flap design or suturing, grafting, membrane placement. We cover a lot of stuff during the 2-day programs. And so these are the classes we have coming up. We take a little bit of break here during the winter. It looks like we're back at it in April. And you can learn more about these on our educational site, which is amplifieddental.com. So again, these are great classes. AMP1 is just extractions and simple grafting, more like an osteogen plug. And then AMP2 Plus is going to be a little bit more involved with the grafting, where you use particulate membranes and flapping and bone leveling and things like that. So at the course, we've had osteogen plug for a long time. It's a really great product. It's not a collagen plug. And if you look at some other graft materials on the market, whether it's a say like a J. Marita Foundation, or a lot of different companies are coming out with plugs, the osteogen plug is the best plug, and anybody that's tried another one always comes back to the osteogen plug. It really just has the best handling and the clinical results. So this is something we've had for a long time. No membrane needed. This is a great product if you have like a 4-wall defect and you don't have to say the buccal plate's not gone. This is a really great way to graft, and the bone quality is great for implants. So if you're not using this, it's something that I would definitely take a look at. This is our graft material. So I know this was already mentioned, but we do have graft material at fair pricing if you're interested. We have a lot of membranes. We stay away from the non-resorbable membranes. We just keep long-lasting membranes that are going to stay in place for the appropriate amount of time. The EpiGuide's great, and that Cytoflex Resorbs probably are two most popular membranes when the case calls for it. And then you don't have to go back in and remove the membrane. So that's a nice thing. Graft kits, we have a full line of instrumentation for your grafting needs. This is the one we really like. If you're using the osteogen plug, you really want to make sure you have proper bleeding, and to use a serrated curette to really curette the socket site prior to placing the graft material. You have better success with the plug. This is the instrument Dr. Burton mentioned, which is the wedge. So it's you'll find that on our website, I think, under elevators. So if you're going to use an instrument to start the extraction procedure, or to extract the tooth, I guess, completely, it's similar to like a luxator instrument, but it has a more comfortable handle, and it's just a little easier to use. This was something that Dr. Nazarian had us make for him. At the class, we do cover the physics forceps. It is our instructor's preferred extraction instrument, but we also have all of the conventional instruments available too. The physics forceps obviously aren't for every case, but that is the product that started our company back in 2007, and we still believe it's a great product. Lastly, I'm just going to mention this before I turn it back over for the questions. We do have So we have the Burton bands from Dr. Burton. We have a great curing light. I'm just mentioning some new things if you haven't checked in with us lately. We have the Quick Connect system, which is a retainerless Tuffelmeyer system. We brought back our purple single-use matrix ring, which has been a great product. And then we do have the other two nighttime rings here that may look familiar, which are going to be your V-shaped type ring, which is more like the Paladin or the Triodent type system, but our pricing is pretty affordable. And then, like I said, we do have the Burton Bands posterior system, which is Dr. Burton's idea. So lastly, I'll leave this up. It's goal 15. Happy to give us a call in the office tomorrow or visit our website. If you're not familiar with GoldenDent, give us a call and we'll be happy to explain further what we have to offer. So I'll turn it back to Lauren and I'll just leave this on the screen during the Q&A session. Thanks, appreciate it.
Thanks, Kurt. Matt, we got a few questions for you. You ready to roll?
Let's do it, man.
Okay, first question. Who makes the mold for the injection molding?
Sometimes I make them in office, and you can use it's actually a bite registration material. It's called Futar, F-U-T-A-R, Futar Fast, and they make a clear silicone mold. So you can make them in-house, or you can have them fabricated by your lab. And so they offer that as well.
Okay. Are you using flowable composite or warm packable composite for that injection molding?
Great question. I am not using flowable. So that was actually Ivoclar Impress that was used in that. So I heated up and I cut slightly bigger holes in the injection mold, and I inject with a packable composite. So those are not flowable restorations.
Good to know. Which lab does your digital planning?
Evident Dental Lab, EVI-DENT does a lot of, they're my workhorse. But my laboratory that does any of my like high-end cases, if I'm involving someone in like veneers or anything like that, it's DISA Dental Lab, D-I-S-A, and they're out of Portland, Oregon, and Bill Murray's is his name, and he's a legend. He's phenomenal.
Okay. For the photos, are you taking photos with the iPad or in combination with like an SLR camera or something similar?
No, just the iPad. Sometimes we have a little ring light in our office as well. We'll drag that into the room, and if we're not getting proper light for whatever reason, because my office faces the south, so sometimes we have plenty of light, sometimes we don't. And so we'll bring that little ring light in, but it's just the iPad, and just turn the portrait feature off when you're taking that. And it just gives them all the information they need.
Okay. Do you recommend flossing after the gingivectomy?
Yes, absolutely. Normal oral hygiene. And I think that's something that it's like the easiest thing to have them do, and they're uncomfortable with it. And so if you make them comfortable or give them a heads up to do it, then they will do it. And then it just really promotes fast healing and great results.
Okay. Let's see here. Have you ever used or thought about using a red light laser PBM to increase healing time and reduce sensitivity after lasering?
No, I have not, but I will. I'll look into that.
Okay. Are there situations where this doesn't work? Are there times where you've had to have kind of a plan B with the guided surgery?
Oh, you always got to have a plan B. Always, but for the most part, as of now, with gingivectomies in those restorative procedures, very predictable. Okay. When it comes to implants and bone and all that stuff, like you have to have a pivot. And so one thing I will mention is that when my lab gives me my guides, they give it based on X size implant, and they know to give me parameters, for if I want to bump up, So if I get into bone where I want to bump up the size of the implant to get a little more, just to get a little more torque on the initial placement, then I know exactly where I'm at. So there's always plan B's kind of factored into plan A, if you will.
Okay. Do you have the specific names of the gingival markers?
Oh, no, I don't, but I found them on, they're on Amazon. I know that. I just searched washable markers that were non-hazardous, right? So for kids, they can eat them and be okay. So just search them on Amazon, you could find them. I think I got a box of 50 and they were like 20 cents each or something. And it's a great transfer of information for very little cost.
Okay. I think we got through all the questions here. Great. Well, anything you'd like to say before we call it a night?
No, again, I just want to thank you, Lauren. You always host an awesome event, and
Thank you.
thank GoldenDent. I really mean that. It's great. I do a fair amount of these, and this one's always it's always awesome. And thank you, GoldenDent, for hosting this as well, and just keeping things going. So I really appreciate it, and I wish everyone out there a good night and a happy beginning to spring.
Well, we want to thank you, obviously, because we know your time is valuable. As I mentioned, these are very popular webinars. The two that you've done, we're averaging 500 plus people. So obviously, these topics are resonating with people, and obviously, you are a subject matter expert, and we're thrilled to have you here. Of course, thanks to GoldenDent, as always. They're the ones that are bringing in Matt and helping to put together the content for these webinars. I do these webinars with GoldenDent on a regular basis. I think the next one is not until April. I'm speaking at Chicago midwinter. I'm going to Guatemala to do some volunteer work. So I think we're not scheduled until early April. All of you who are here this evening are on the invite list for the next webinar. So that usually starts to go out about 3 weeks ahead of time. As a reminder, and if you showed up late, you didn't hear this, two things. Number one, the webinar has been recorded. You should get a copy of that recording within a couple of days. I'm going to send it off to Kurt in the next hour or so they'll be able to send that out. There are CE credits available for this webinar. You have to have been here for the bulk of the webinar. I think it's either 2/3 or 3/4 or whatever. There's nothing that you need to do. When you log off, you log off. There's no registration or quiz or test or anything like that. I will send the report to Kurt. It'll show what time you logged in, what time you logged out, and as long as you meet the criteria, you'll get the CE forms. They often get those out within 3-4 days. It can take about a week sometimes. If you don't have it, say, by next Tuesday or Wednesday, feel free to reach out to me. I'll follow up with Kurt, and they'll get that out to you right away. We thank all of you for joining us because we know your time is valuable as well. And I continue to do these webinars because we get good turnout, and I'm getting good feedback. So thank you all for joining us. Please stay safe and healthy. I know there's some snowstorms coming in around the country. We're going to get a lot of rain, much needed rain here in Southern California. But please stay safe out there. And we look forward to seeing all of you on future webinars. Good night, everyone.